For $2 a year, the average American worker had unlimited access to a physician, not $2 per visit, $2 total. For everything, house calls, surgery, middle-of-the-night emergencies, all of it. That was not charity. That was not a government program. That was the going rate, and it lasted for over half a century. The contract sat on the table at the monthly lodge meeting. The Odd Fellows Hall, usually, or the Moose, or the Freemasons, every fraternal society in every American town with more than a few hundred people had one. The men voted on which doctor to hire for the year. The doctor who won the contract agreed to treat every member and every member's family. Unlimited visits. The lodge paid him a flat fee from the dues, $1 to $2 per member per year. No paperwork, no claim forms, no pre-authorization. If you were sick, you went to the doctor. If you couldn't walk, the doctor came to you. The system ran on a handshake and a ballot. But there is a date, one specific date, when this became structurally impossible. Not illegal, not yet, just impossible to sustain. And the question I kept returning to is this. If the lodge practice system provided unlimited physician care for the cost of a single day's wages per year, why does the average American now spend the equivalent of 6 weeks' wages annually on health insurance alone, and still pays out of pocket when they actually see a doctor? If you enjoy these stories, support the channel by subscribing and liking. Now, back to the story. Here is how it actually worked. You joined a fraternal lodge the same way you joined any voluntary organization. You applied, you paid your initiation fee, and you started paying monthly dues, 25 to 50 cents a month, typically. That bought you more than medical care. It bought mutual aid if you were injured and couldn't work. It bought life insurance for your widow. It bought a network of men in other cities who would help you find work if you had to move. But the medical contract was the backbone. Every year, the lodge opened the bidding. Local physicians submitted their proposals. I will provide unlimited care to all members and their families for X dollars per member annually. The lodge voted. The doctor with the best combination of price and reputation won the contract. That doctor became the lodge physician for the year. The lodge paid him from the treasury, a lump sum, or sometimes in monthly installments. The amount varied by location and lodge size, but the average hovered around $1 to $2 per member. In 1898, Seattle's Scandia Lodge contracted with Dr. Peter Anderson for $1.50 per member per year. In Los Angeles, by 1910, there were over 200 such arrangements active simultaneously. You went to the doctor as many times as you needed. No additional payment. The doctor's income was fixed, so he had no financial incentive to overtreat or undertreat. If you needed him at 3 in the morning, he came. If you needed surgery, he performed it. The only services not covered were extended hospital stays requiring specialist care, and even then, the lodge often negotiated group rates with the hospital. The lodge practice physician was a general practitioner. He handled everything a general practitioner could handle, and in 1900 that was nearly everything most people needed. The system worked because of scale and selection. A lodge with 300 members generated $300 to $600 a year for the physician. That was not a fortune, but it was guaranteed income. The physician knew exactly how much he would earn, and he could build a practice around that baseline. Meanwhile, the lodge benefited from competition. If the current physician raised his rates too high, the lodge voted him out and hired someone cheaper. If he provided poor care, same result. The accountability was immediate and direct. No corporate intermediary, no billing department, no insurance company deciding what was covered. The word insurance itself comes from the Latin securus, to make safe, to make certain. The lodge system operated on a different principle entirely. It was not insurance against an uncertain cost. It was certainty of access at a known price. The member paid a fixed amount. The physician received a fixed amount. The arrangement was transparent from both directions. When you remove the uncertainty from both sides of a transaction, you remove most of the administrative structure built to manage that uncertainty. No actuarial tables, no risk pools, no claims adjusters determining whether your visit was medically necessary. The lodge treasurer paid the doctor. The doctor saw the patient. That was the entire apparatus. But the system had limits. Rural areas with only one doctor couldn't sustain competitive bidding, and physicians complained, loudly, in medical journals throughout the 1900s and 1910s, that the flat rate payment was too low, especially when certain members needed frequent care. A member with chronic illness could cost the physician far more in time than the annual contract fee covered. The financial risk sat entirely with the doctor, and that is where the tension began, not with the patients, with the physicians who wanted to be paid differently. The AMA's own journal published physician complaints as early as 1906. Contract practice, they argued, reduced doctors to wage laborers. It undermined professional autonomy. It attracted inferior physicians who could not build a private practice. The language in these articles is telling. The objection was not that patients received poor care. The objection was that physicians were paid in a way that limited their income and their independence. That distinction matters. The conflict was not clinical. It was economic. This is the system that worked for more than half a century in nearly every American city. We have not yet explained what ended it. By 1920, nearly 1 in 3 American men belonged to a fraternal lodge. That is not an estimate. That is a head count. The census data, cross-referenced with fraternal membership rolls, puts the figure between 30 and 35% of the adult male population. Their wives and children accessed care through the husband's membership. The lodges were not small or peripheral. They were the primary medical delivery system for the American working class. The scale of this is difficult to grasp from a modern perspective. Imagine if 1/3 of American workers today belonged to a voluntary organization that provided their families health care for less than 1% of their annual income. Imagine if that organization was also their social network, their life insurance provider, and their unemployment safety net. And imagine if all of it operated without any government funding, any corporate involvement, or any professional management class. That was the lived reality for tens of millions of Americans. And most people alive today have never heard of it. David Beito, a historian who spent 2 decades reconstructing this system from scattered lodge records, described a man named William Harrison. Harrison worked in a Chicago meatpacking plant. He joined the Independent Order of Odd Fellows in 1903. His monthly dues were 35 cents. For that, he received medical care, a death benefit for his wife, and unemployment assistance if he was injured. In 1907, Harrison's daughter contracted scarlet fever. The lodge physician, Dr. Edward Morrison, visited the home 4 times in a week. No additional charge. The girl recovered. The total cost to Harrison that year, $4.20 in lodge dues. That covered 12 months of potential medical care for a family of 4. $4.20. For context, Harrison earned roughly $300 that year working at the plant. His health care cost him less than 2% of his annual income, and that figure included not just the medical contract, but also death benefits and mutual aid. The medical portion alone was under 1%. A modern worker earning $50,000 per year pays, on average, over $6,000 in premiums alone before any actual medical care is delivered. That is 12% of income, and it does not include deductibles or co-pays. Harrison died in 1953, 50 years after joining the lodge. The lodge itself dissolved in 1960. His grandson, interviewed in the 1990s, said Harrison talked about the lodge physician the way people now talk about a family member. The doctor knew every person in the lodge by name. He attended weddings. He sat in the same hall for monthly meetings. If you saw him at the market, you could ask a medical question, and he'd answer it on the spot. There was no separation between the physician's professional life and his community life. He was paid to be available. And he was. The grandson also said something else. He said that when employer health insurance became available at the meatpacking plant in the late 1940s, Harrison refused it. He kept paying his lodge dues even as the membership dwindled, even as younger workers took the employer plan, even as the lodge struggled to find a physician willing to accept the contract. Harrison stayed until the lodge folded. When asked why, he said he preferred a doctor who knew his name. The grandson did not understand the answer at the time. He does now. That world, the world where a Chicago meatpacking worker could raise a family with full medical access for the price of a dozen loaves of bread per year, was about to meet something that would make it structurally unsustainable. Not because it failed, because something else was built. April 1910. The Carnegie Foundation published a report titled Medical Education in the United States and Canada. The author was Abraham Flexner. Flexner was not a physician. He was not a medical researcher. He had never attended medical school. He was an educator who had previously run a for-profit preparatory school in Louisville, Kentucky. His only major publication before this report was a book about his own teaching methods. The Carnegie Foundation paid him to visit every medical school in the country and evaluate their quality. The Flexner Report, as it became known, recommended the immediate closure of the majority of American medical schools. Flexner argued that most schools were plague spots, producing inadequately trained doctors. He called for strict standardization, university affiliation, full-time salaried faculty, expensive laboratory equipment, extended coursework. Schools that could not afford these requirements should close. Of the 166 medical schools operating in 1910, Flexner recommended fewer than half remain open. Within 25 years, the number of medical schools dropped to 66. 5 of the 7 medical schools that primarily served black students closed within 15 years. The number of physicians per capita began to decline, and the cost of becoming a physician rose sharply because the schools that survived were expensive university programs requiring years of full-time study. Here is the detail most accounts omit. In 1909, 1 year before Flexner's report was published, the American Medical Association created the Council on Medical Education to rate medical schools. The Carnegie Foundation provided a $10,000 grant to the AMA's council to fund the study. The AMA gave the contract to Flexner. 1 year after the report was published, the Rockefeller Foundation began donating $50 million to medical schools that adopted Flexner's recommendations. That is not $50 million adjusted for inflation. That is $50 million in 1910 dollars. The money flowed to schools that required full-time laboratory faculty, university affiliation, and the kind of infrastructure that made cheap, accessible medical training impossible. The Flexner Report does not mention lodge practice, not once. It does not mention fraternal societies. It does not mention contract medicine. The report is concerned exclusively with the quality of physician training, not the structure of medical delivery. But the consequence was indirect and total. Fewer medical schools meant fewer physicians. Fewer physicians meant less competition for lodge contracts. Less competition meant physicians could demand higher rates. Higher rates meant lodges could no longer afford the arrangement. And at the same time, the AMA, whose membership grew from 8,000 physicians in 1900 to over 70,000 by 1920, was publicly campaigning against contract practice. The AMA's journal began publishing articles in 1912 calling contract practice unethical. The argument was that flat-rate contracts undermined the physician's professional independence. In 1917, the AMA's Judicial Council formalized the position. Contract practice was declared incompatible with the AMA's principles of medical ethics. State medical boards, increasingly controlled by AMA members, began enforcing the standard. A physician who participated in contract practice risked losing his license. The old system did not collapse in a single moment. It bled out across 2 decades. By 1930, lodge practice had contracted to a shadow of its former self. By 1940, it was nearly gone. Meanwhile, a replacement was being built: employer-sponsored health insurance. It began during World War II, when wage controls prevented companies from raising salaries to attract workers. The 1942 Stabilization Act allowed employers to offer health insurance as a non-wage benefit, and the IRS ruled that the insurance was not taxable income. A worker who received health insurance through his employer paid no tax on that benefit. A worker who paid a doctor directly or who paid dues to a fraternal lodge received no equivalent tax treatment. The incentive structure tilted. Employer insurance grew. Lodge practice withered. The cost of that replacement is best understood in direct comparison. In 1900, the average lodge member paid $2 per year for unlimited physician access. Adjusted for inflation, that is roughly $70 to $80 in 2024 currency. The average American now pays over $7,000 per year in health insurance premiums, and that does not include deductibles, copays, or out-of-network charges. The average American sees a physician 4 times per year. The cost per visit, after insurance, often exceeds $100 out of pocket. Do the arithmetic. $7,000 in premiums plus $400 in out-of-pocket costs for 4 visits equals $7,400 annually. That is nearly 100 times the inflation-adjusted cost of lodge practice. Not 10 times, not 20 times, 100 times, for fewer physician visits per capita than lodge members received. The efficiency loss is difficult to explain through any conventional economic model. The organizations that grew as lodge practice contracted were insurance companies and hospital networks. In 1940, there were fewer than 10 major health insurance companies in the United States. By 1960, there were hundreds, covering tens of millions of workers. The insurance industry's revenue in 1950 was measured in hundreds of millions of dollars. By 2020, it was measured in hundreds of billions. The AMA, which spent 50 years campaigning against lodge practice, became one of the most powerful lobbying organizations in Washington. Physicians' incomes rose sharply after lodge practice ended. In 1920, the average physician earned roughly twice the income of the average worker. By 1950, that ratio had grown to 4 to 1. No one orchestrated this as a conspiracy, but the sequence of decisions, the Flexner Report, the AMA Ethics Code, the tax treatment of employer insurance, the rise of corporate health networks produced a result. The system that had provided affordable direct access to physicians for 50 years became structurally impossible to sustain. And most people who now purchase health insurance have no idea that an alternative ever existed. We still have not answered the question from the beginning. If lodge practice was inferior, why did anyone fight to keep it? They did. The evidence is thin, but it exists. The most visible remnant survives among the old order Amish. Amish communities do not participate in Social Security, Medicare, or commercial health insurance. They were granted a formal exemption in 1965, but they had to fight for it. The Amish applied for the exemption in 1961. It took 4 years and direct congressional intervention to secure it. The exemption allows Amish communities to maintain mutual aid systems. When a member faces medical bills, the community contributes to a shared fund. The bills are paid collectively. The Amish negotiate directly with physicians and hospitals for cash payment at significant discounts. Physicians accept the arrangement because payment is immediate and certain. No billing department, no insurance paperwork, no delayed reimbursement. The Amish pay less than insured patients for the same services, and the physicians still prefer the transaction. That arrangement, direct payment, no intermediary, negotiated price, is nearly identical in structure to lodge practice. It works. It works now. And it required a specific act of Congress to keep it legal. Why did it require congressional intervention? Because state insurance regulators in multiple states had begun investigating Amish mutual aid funds as unlicensed insurance products. The funds had no actuaries, no reserves calculated according to state formulas, no licensed agents. Under state insurance law, they were operating illegally. The Amish had to petition Congress to carve out an explicit exemption. The petition was not granted easily. It required testimony, documentation, and 4 years of legislative process to accomplish what should have been the simple continuation of a practice that had existed for centuries. A modern descendant also exists, though it is small. Approximately 1,200 physicians in the United States practice what is called direct primary care. The model is simple. Patients pay a monthly subscription fee directly to the physician, typically $50 to $150, and receive unlimited primary care visits. No insurance, no third-party billing. The physician's income is predictable. The patient's costs are fixed. It is the lodge practice model, revived. But direct primary care physicians have spent the last 15 years fighting state insurance regulators to keep the model legal. 37 states required specific legislation to define direct primary care as not insurance and therefore not subject to insurance regulation. Without those laws, state insurance boards would have classified the subscription model as an insurance product and regulated it out of existence. The legal battles are documented. The physicians won, but they had to win state by state. In Kansas, the insurance commissioner issued a cease and desist order to a direct primary care practice in 2013, claiming it was selling insurance without a license. The practice had to hire attorneys, petition the state legislature, and spend 2 years fighting for the right to charge a monthly fee for medical care. The legislature ultimately passed a law explicitly stating that direct primary care is not insurance. 36 other states went through variations of the same process. Each time the physicians had to prove they were not doing something that lodge physicians had done routinely for 50 years. If the old system was genuinely inferior, if employer insurance and third-party payment truly represented progress, why did the Amish have to petition Congress for 4 years to opt out? Why did direct primary care physicians have to fight state regulators in 37 states to preserve a payment model that patients and doctors both prefer? The answers to those questions are not in the data. They are in what happened to the knowledge of how the old system worked. By 1960, the generation that remembered lodge practice was dying. Their children had grown up with employer insurance. The grandchildren had no memory of any alternative. But the forgetting was not passive. It was structural. The Flexner Report became the foundational text of American medical education. It is still cited, still taught, still referenced as the document that modernized medicine. The report does not mention lodge practice, and neither do the medical school curricula built on its recommendations. Medical students learn the history of antiseptics, anesthesia, and germ theory. They do not learn that 1 in 3 American families once accessed physician care for $2 a year through a voluntary association. In 1917, the AMA declared contract practice unethical. That classification remained in the AMA's ethics guidelines for decades. Physicians trained after 1920 were taught that direct contracting with patient groups was professionally inappropriate. The reason was not explained in clinical terms. It was presented as a matter of professional standards. And professional standards, once established, are rarely questioned. The records of how lodge practice functioned were not preserved in any central archive. Fraternal societies were private organizations. When the lodges dissolved, most between 1940 and 1970, their records were discarded, donated to local historical societies, or lost. There is no national repository of lodge medical contracts, no comprehensive database of which lodges hired which physicians, or what the outcomes were, or how the system handled edge cases. The information exists only in fragments, scattered across state archives and local libraries, accessible only to researchers willing to spend years reconstructing it from primary sources. David Beto published the first comprehensive academic treatment of fraternal lodge medicine in 2000. The book is titled From Mutual Aid to the Welfare State. Before that, the topic was absent from medical history literature. It was not suppressed in the sense of being actively hidden. It was simply not taught, not written about, not remembered. The institutional mechanisms that might have preserved the knowledge, medical schools, public health departments, government health agencies, had no reason to preserve it because the system they were built to support had replaced it. The absence is what strikes you when you start looking. Major academic histories of American healthcare published in the 1970s and 1980s contain no index entries for fraternal societies or lodge practice. Textbooks used in public health schools do not mention it. The standard narrative of American medical history jumps from individual fee-for-service physicians in the 19th century to employer insurance in the mid-20th, with nothing in between. 35% of the population participated in an alternative system, and it left almost no trace in the institutional memory of the medical profession. When Medicare was debated in Congress in 1965, the transcripts run to thousands of pages. Legislators discussed costs, coverage, physician reimbursement, and hospital networks. The word fraternal does not appear. The phrase lodge practice does not appear. No one in the debate mentioned that 30 years earlier, millions of Americans had accessed medical care through a completely different structure. It was not argued against. It was not considered. It had already been forgotten. The root cellar sits beneath the kitchen floor, packed earth on 3 sides. The temperature never rises above 55 degrees, summer or winter, without a single moving part. That room was filled in during a single decade. Not because it stopped working, because something was built that made it unnecessary, and then made it illegal. The lodge contract sat on the table at the monthly meeting. The Odd Fellows Hall, the Moose, the Freemasons, every fraternal society in every American town. The men voted on which doctor to hire for the year. The doctor came when you called. The cost was 1 day's wages, paid annually, for unlimited care. And then it ended. Here is what I cannot answer. If the system was abandoned because it was inferior, why does every attempt to revive it require legal exemption? If employer insurance represents progress, why does it cost 100 times more and deliver fewer physician visits per year? If the Flexner Report modernized medicine, why did the physicians who lost lodge contracts fight so hard to keep them? If the AMA's ethics code protected patients, why did it take 37 state legislatures to protect doctors who want to contract directly with patients again? If the old system failed on its own, why did it take $50 million, a change to the tax code, an AMA ethics ruling, and the systematic exclusion of lodge practice from every medical school curriculum to make sure no one remembered it existed? And if I am wrong, if the lodge practice system truly was unsustainable, outdated, and inferior to what replaced it, then why can I still find the Amish doing it right now and paying less than everyone else? Why did William Harrison refuse employer insurance and stay with his lodge until it closed? Why does every resurrection of the model, whether Amish mutual aid or direct primary care, require years of legal battles to survive? The contract is still on the table. We just forgot we were allowed to vote.